Thank you, all three. I'd like to see your scar at some point, maybe on a break. Well, we left a lot of time for discussion between now and lunch, and I hope that people have a lot of questions. I know I have one just in listening to the three of you. What I started to hear is the emergence of a transparency tension, where there's, on one hand, we have the movement toward open notes and data for good, and on the other hand, we have this notion of knowledge as a commodity and data privacy issues. So I would love to know where the three of you think we could go in terms of turning the tension around transparency into a positive.
So I think it's worth understanding the difference between transparency of knowledge and ability to execute. So, we've spent a lot of time developing models, and we take the literature that's out there, right? Geisinger generates very little new, sort of groundbreaking research. But we take what's out there, we figure out how to put it together and deliver it in a reliable way. And we're very free with that level of knowledge. So the process for delivering it. Now, if you want us to help you actually do it, that takes time, energy, and people that we expect to be paid for. So it's the difference between execution and knowledge, and we're very free about the knowledge, less so about the execution.
So another hat I wear is I sit on Yale's Open Data Access Steering Committee, and Harlan Krummels has been working with a number, well, first it was Medtronic and now Janssen Pharmaceuticals, to open up the data files and make them more accessible. And the issue came about because there were problems related to lack of transparency of data, and there's lots of problems. One of my areas of research is in medical devices, and certainly a lot of the clinical trials for drugs and devices that go for FDA approval remains secret and proprietary. What gets published is published. That's a very small part of it. And so I think open data is a really important part of improving quality and improving high-value care, because, as I said, it's very hard to know if you're doing the right thing when you haven't looked at all the data. And unfortunately, and patients are harmed. I mean, not just are we spending billions of dollars on healthcare that has not actually been shown to be beneficial, but there are examples, and I won't go into all the details now, of where there was harm because data was knowingly withheld. And so, but even, for the sort of cardiovascular, the registries that we have, and I think the registries are great, but I do think we need to have more transparency and public availability and accessibility so that people understand risks and benefits, and that can only be done in an open data, transparent environment.
Yeah, so I heard your question about the tension portion of it, because part of this, I think people are all probably in agreement, at least at the concept level, or the idea of transparency. Then you start getting into the specifics about the implementation or the execution, or at what level, and then that's where that camaraderie starts to fall apart a little bit. I also think there's questions about if we're not cautious about what we're talking about, then you have other unintended consequences or free rider effects and things of that nature. And so I'm not certain we've solved that particular nugget yet. I think we're all in agreement of moving forward with transparency, and I think we're starting to see more and more access to the data and more performance results. But in terms of the question, I think for this particular panel, which is a sustainable model, we don't have that. And so I think part of this tension reflects the fact that we don't have a model that addresses some of these investments. If people are making individual investment, whether it be for their own individual institution or for whatever organization they are, and then we want people in somehow to be altruistic and forgo their investment for the greater good, then we need some type of model that rewards that sacrifice that they're making. And I think that's part of the tension, is we don't have a model yet that has solved that issue.
And I think that there's also a bit of a quandary around who owns the data, which Vicori felt acutely last week and as we were talking with some of the media. So I'm starting to see some hands for questions. If you could introduce yourself and use the mic.
Steve Finn, VA. I'm fascinated, Trent, by your discussion, and I'd love to have you sort of maybe dive a little deeper into this notion of placing value on knowledge. Obviously, if there's a way for a health system to save money and maintain quality, we certainly see the competitive value in that. Some of the things may actually not have market value, may have negative market value, right? High quality things in which patients believe they're being deprived of some service, don't have value until they're normalized in some fashion through some quality measurement system. Could you actually sort of tease out maybe sort of the ways in which knowledge could be valued as opposed to those that sort of directly relate to sort of improvements in the bottom line?
Sure, I'll start that conversation, and of course, value is a really packed term. But part of what I was getting at, maybe, and see if I'm answering your question, is one of the things that even early on, again, this even predates my current role. This goes back to my role. David knows this role well when I was down in Texas as VHA Chief Medical Officer, where I spent a lot of time working with health systems, trying to support their quality improvement efforts and things of that nature, as my former colleagues at CMS was continuing to move forward in the value-based payment model. Was, well, how does this really going to play out? Because the way that we're structuring is that we're structuring in such a way that you're going to have kind of quote unquote winners and losers. And we were starting to ask the question, well, if we're structuring that model, which is not unreasonable model, but the logical conclusion, even though healthcare people are much more altruistic than this, I think, which is why we can get away with this. But if you were just playing it out from a normal logical perspective, you would end up saying, well, shouldn't there be knowledge hoarding? Because if you're putting me in this particular model and I'm going to get the benefits out of being able to identify something first, solve that nugget first, then what incentive is it for me to go around and share that with others unless you have some mechanism by which you're going to also tie that into it, whether it be social capital, whether it be an actual financial incentive. And so part of what we were thinking about even early on was, how do you actually put in place incentives for the diffusion? So if you actually saw that whatever the issue is, and we all validate that it is that type of practice, how do you get the downstream benefits of that? Again, that might be a combination of social capital and recognition of that, as well as real financial incentives. And so those are the things that when you're asking about value, that we're early in these throes, but I think if we're talking about a truly sustainable model for people that have made investments on the front end, because keeping in mind, when you're making that investment on the front end, it might flat out fail. And you definitely aren't going to get any return on those particular investments, right? And so say you try something, I forgot, someone mentioned about hypertension or something that didn't necessarily work well, right? Where we're talking about failing faster. But for those things that do end up, you're being innovative, you're on the cutting edge, you're telling your culture that this is for the greater good of the community, then let's say you are having success 2 out of 10 times or whatever the case may be, then how do you actually make certain that the model rewards the fact that you had to make multiple investments to get that one return or those 2 returns? And so that's what we're thinking about. It's like, how do you support that diffusion and make certain that people are able to get that return on that investment for that upfront investment? Am I answering your question?
To an extent, it seems to me some of these don't have value unless you diffuse it, right? You may find that the outcomes of care through a cheaper way, which would be perceived by patients as less good because, that hasn't been disseminated, might actually not be a market value till it becomes an accepted performance measure, if you will, and you can show you're at 90% on that. There may be other models in which essentially those things get monetized. I was just curious if you had thought about that.
So it seems to me that one of the questions that we keep coming back to is the various tensions that exist between the clinical delivery of care and the research. And one of the issues that I struggle with is, how do we identify and develop those knowledge markets appropriately? So we've got everything from the clinical investigators through the clinicians who are actually delivering care up through health systems executives like me. And it just seems that we don't necessarily, this is a good starting place. We've got now 50 or 60 organizations here, but there are thousands of places where care is being delivered. And if we think about the adoption of evidence-based medicine, which really has not occurred nearly as rapidly, I think, as we want. My question is, how do we develop those knowledge markets so that the things that we are learning can be disseminated much more rapidly? It's great to develop the knowledge quickly, but how do we get it out so that we have it available to kind of that very eclectic mix of people who have to be involved in researching, understanding, and then implementing? And I'm not sure that we've really come up with a good solution for that yet.
Certainly one solution, and it, I think, worked well. I mean, you want to comment on the reduced MRSA trial, but I mean, is sharing through publication in peer-reviewed medical journals, because then it becomes available, so that's my suggestion.
So part of reason why I even gave that example with the childhood story, and also so you don't fall asleep right before lunch, is if you think about it, and I often do this, is watch children as they obtain knowledge and things of that nature. Is part of, I think, part of what we're right now have actually structured models that make it difficult to actually obtain knowledge. So I have to go out of my normal routine practice. When I used to follow people that were taking care of patients, like for performance improvement purposes, and follow them around, right now most of that knowledge is not actually embedded within their routine practices. They would have to either take time out and go to the hospital library, or they would have to take time out to have a specific, okay, now it's time to huddle and have a meeting, and people are trying to stop what they were doing from their clinical care and huddle. So part of the issue, I think, and the reason why I was talking about the children, is that if you think about what children are doing, they're embedding it within their routine practice, right? That's what they've done. They've basically socially constructed that marketplace in a place where they would normally be occurring anyway. And I know some that are doing implementation science, that's what is trying to happen with the team huddles and things of that nature. I'm not so certain that we've done it well yet, or that we've put that model in place successfully yet, which is what I'm hoping maybe part of the dialogue in the next day and a half will stimulate that, to say, okay, if we're really going to be successful, part of this has to be, we have to be honest about the model, even like with peer-reviewed journal articles, which are great. But I was just sharing with Sarah my schedule this week. It is literally me having to do that on planes and at night, and it was the Easter holiday, which meant after all the family had like eaten dinner, and hopefully everybody's put to bed. Now you're trying to pull out some peer-reviewed journal articles so you don't fall behind. But you really are forcing people right now to stop something to grab the knowledge, which is very different than if it was actually social constructed based upon their routine practices.
So the other issue is, clearly we need to create the knowledge, we need to publish the knowledge, we need to make it available, but just doing that won't get it done. We need to create a system of care that reliably delivers it. It can't rely on the diligent efforts of human beings, because guess what? There's no way you can work hard enough to get all of that knowledge, even if you had it available, which is another challenge, to every physician or every nurse that needs it. Right? So just like having the knowledge isn't necessary but insufficient, right? There's also all this emphasis on pay for performance, and what we've done historically is pay for metrics. Patrick is gone, so I can talk. But this concept of just putting the cheese there and everyone will suddenly run to the cheese, yeah, that's great until you realize that either you need 8,000 pieces of cheese because there's a million things you need them to do, or you move the cheese, and what happens when you move the cheese? You move the performance. So you need to reward folks. That's necessary, I agree. You reward them to participate in the system. The system is what reliably produces the results. And I think that's a fundamental area that we need to focus on. We spent a lot of time working through this at Geisinger, and just giving people feedback, just giving, if there's a knowledge deficit, you got to fix the knowledge deficit, otherwise nothing happens. Absolutely. Giving them the feedback, yes, that's incredibly important, but just telling Michael Jordan that he's batting 200 over and over again was not successful in improving his baseball skills. What you need to do is tell them you're batting 200 because X, Y, and Z, and so share those, but also build the system so that the right thing to do is the easiest thing to do. Make it as easy as possible for each of the individuals in the chain to get the right answer. Then they can focus on that 10 or 20% that really does need to be individualized, really does need to be customized. It's a challenge we get about cookbook medicine, and my response is, well, even the best chefs start with the recipe. Let's start with the recipe. Yes, customize it to the patient where it needs to be, but most of the stuff that physicians need to do, it's repetitive, right? We didn't go to medical school to do the same thing over and over and over again. Well, when you care for patients with diabetes, you do the same thing over and over again, 90%. And then there's that 10% that's different. Focus the docs on the 10%, make the 90% automatic. I never have to type the word screening mammogram again in my life, regardless of what age group. And I'm not afraid of that. I'm not sorry for that. I think it's great because the system is designed. My decision, my clinical decision making, the complex medical decision making is the standard protocol appropriate for this patient or not? If the answer is yes, it just happens. And I can focus on those handful of patients where it's not and what should be done for them. That's where I think we need to get. We need to build these systems of care that don't rely on the foibles of humans, because guess what? We'll screw it up every time.
Yeah, so I would just say that, maybe one core principle of the learning health system is we're going to make it easier to do the right thing. Hopefully we can get there. So lots of other questions. So Hal?
So, and I'd like to go back to the question of how we actually generate and get the knowledge out there. And I'm wondering, and I'm going to tee this up as a question maybe for Susan, about the history of that MRSA project. Because my speculation here is that there was the serendipity of two people coming together. But then HCA, lots of hospitals, probably not a major research enterprise, but very interested in quality improvement. Reducing MRSA, it may or may not lose money or gain money for them, but getting reputation for doing that is probably positive. Rich Platt, knowing how to run an IRB across multiple sites and being able to execute quickly. A young researcher who wants to get this thing done. Maybe some funding, how did that happen? And saying we're going to get this done very quickly and not with a standard process. And that, so each of those parties had different interests. Had they not been brought together, my speculation is that never would have happened. And with an agreement that the finding, if you found that none of them worked, or maybe that outcomes were worse, you would have published that, right? So just a little bit of what are the ground rules, how can we align incentives and get people together, maybe the way to move it forward.
I think that you're absolutely right, that in order to start with the right wins, you have to find the places where synergy already occurs. And I think that you can deliberately go find them because there are incentives, sometimes financial, sometimes transparency incentives, sometimes a small portion of value-based purchasing is moving in a direction where you see it coming. And I think if you start there, those are the easiest ones to get a win. And I think there are many others where it's much more difficult to figure out where that synergy lies. And we just slowly have to start with one circle and find the ways to keep expanding it. And we need to get people in the same room together or the same playground to know where, because we are driven by totally different things. And you're right, if there wasn't a history in HCA already where they had invested in MRSA because they thought it was a high quality target and they were looking for the next win, they'd already declared one win, looking for the next, I actually think it would not have happened. So you're absolutely right that we need to find those circles first because we can't tackle the hard ones before we figure out what the low-hanging fruit are.
Great. Good morning. Thank you again for the opportunity to join this meeting. I'm an Associate Vice President for Population Health at the University of Illinois. We are a safety net health system. And as I was reflecting on this conversation, I think one of the areas in which the value proposition is a little squishy, but one that probably that ought to be made a little bit more clear, is the value proposition for patients for research. We've been engaging patient groups now across a variety of areas, and we've been largely successful at getting some of the PCORI contracts because it's very clear the energy and passion is there, and they're looking for partners in order to be able to move it from concern, anxiety, fear, distress, feeling like they're lost, feeling confused with all the options, the treatment options that exist, with actually the opportunity to move that forward into a structured research question with a protocol and an application. And that's at least what we've been seeing. But what I'd like to ask is maybe a trend from a payer standpoint. Do we know, has there been some calculation of how do patients value research? Do they value a payer who is doing research in order to be learning how to deliver better care, or in order to learn how to bring providers to deliver better care? Just wanted to see what the perspectives were among the panelists here about what do we know about patients and how much they value research.
So I'm going to see if other panelists know that specific question, because as it relates to the insurer or the payer, I don't have that information in terms of if a payer is supporting or doing research, does it impact the way in which the consumer might value that particular research? I don't have that knowledge or that information.
Yeah, I mean, sorry. Patients certainly value organizations that participate in research, right? So it's reputational, it's, this concept that, continuous learning. Many of them, more sophisticated ones, want to go where research protocols, cancer is an obvious area, right? So what are the protocols that are being run so that they're getting the latest care in that area, whether it's real or perceived? I think they do put a value on it. Patients' willingness or interest to participate in research, though, because we see it from both the payer and the provider side, is really more around the trust issue and their value of their physician and the physician request to participate in research. So we have patients that are willing to donate blood, to donate tissue, to donate with virtually no, with no hesitation. The numbers that allow participation in research or sign up for research are significant. Some of it too depends on how you translate it into the patient arena. So, our rheumatology patients or rheumatoid arthritis patients fill out a 100-item questionnaire with every office visit. And I don't think it's just because they are old and they have nothing else to do. I think it's because they see it immediately spun in turn directly in their care. Now, much of the research that we do or participate in, that linkage is not nearly that direct, right? It's not, you filled it out and during that office visit, it's used in your care as well as improving the care of the program. But building that connection for them on an ongoing basis is critical. Having said that, I don't think folks are switching doctors from the guy down the street to come to see me because we do research.
I mean, just to add, I thought you were also maybe going for how do we pay for all of this research, and who's going to benefit? I mean, certainly I think patients certainly do see the value in research as a public good and also research that will improve their own health care. But I think, when I think David was saying it was 40 cents per patient per month, essentially group health, and I was thinking, it was a very interesting idea to sort of have part of our healthcare, because we know that comparative effectiveness, and I heard pretty clearly when Joe said, we need a sustainable model. Clearly, PCORI is not funded to do, the kind of work that we really need. And I mean, as I said, as the IOM Medicare at lower cost estimated, $1 trillion a year is wasted, and I think, well, if that could be redirected, if we, had research that showed us what was helpful and what wasn't, it's not that we don't have the money in the system, but we're not allocating the money in our system right now in a way that helps to coordinate research efforts. So I think patients do value it, but we need to really educate patients even more on how important it is. And I think, one of the, unintended consequences of the changes in ACA is that there are a lot more out-of-pocket costs, and when patients start realizing that they're now paying for a lot of this expensive health care, then there's more of an incentive personally to know what's working, what isn't, because you certainly want to pay for what works, but you don't want to pay for what doesn't.
If I could just add one clarifying, the reason I asked that is because right now with the ACA implementation, a lot of health systems are trying to understand how to remain competitive in the marketplace and retain their patients or to be able to add patients to their roles. And we're making a bet at the University of Illinois that being a learning healthcare system, and we're some ways from there, but if we're moving in that direction, we would be more attractive to the patient marketplace. And I think that may be one of the mechanisms, if we can start to understand that equation, if there is an equation, to be able to measure it, that may be one mechanism to more tightly involve health systems and be able to support this infrastructure, because then they could be seen as a market leader, generating new knowledge, implementing new knowledge, and at the forefront. We talk about it, but I'm not sure that everyone's there's any empirical data on that.
My name is Lorraine Johns, and I'm the patient representative for PCORI. And I just wanted to say that I think this question about what patients value in research is a context-dependent question. So it comes back to some of the value propositions we were talking about earlier. What are my risks in being involved in the process? What are my risks in terms of data privacy? What are my risks in terms of foregoing possibly an individualized decision being made? And what are my benefits? Is this research that's being put together that's going to answer a question that I find critically important? Is it going to change my life? Is it going to change my care? And I do think that the question of trust is a really fundamental question, and sort of bridging and building, going back to your question, Trent, this question of building a social contract so that it works, so that the benefits that the patients are receiving from the research are apparent, and the trust parameters are put in place. I think those are critical things that need to be done.
Thanks, Lorraine. Just one quick comment. And I think it's a great question, and I agree with Lorraine that it is quite context dependent. I'm tempted to take the devil's advocate view here, because I think if I'm a patient and I don't know anything about what's going on in this room today, and I have a choice of going to a learning healthcare system and a health system, I hear a learning health system and I'm like, I don't want a health system that learns. I want the one that knows, right? So I think we need to be really thoughtful about this and consider that we don't want to be in a bit of an echo chamber. I'll just say that, and then I'll go to David. And then there's a lot.
I just want to follow up on Steve's point to Trent and suggest for some comment the idea that maybe just put forward a proposition that I think one of the other perspectives that we need to take into account is the fact that we're dealing with different delivery systems that come from both the for-profit world for which there's an additional stakeholder, the shareholder, which commonly is not discussed, for nonprofits, in which we have a stakeholder being in importance of many institutions here having to prove their 501c3 worth, that they deliver community benefit, increasingly coming under challenge for that. And so the question is to what degree, because does 501c3 status actually serve as an incentive for distribution of knowledge as a community benefit? And the third is government, which, like the VA is represented here, and the VA represents a completely distinctive perspective, which is that they represent the public perspective, which is really the third. Group health, being a consumer governed organization like Health Partners in Minneapolis, perhaps has, to one end of the 501c3, the consumer governing board has a particularly strong attitude about public distribution of knowledge. But I would argue that similar in the for-profit sector, that perhaps the major advantage for us from a business perspective would be the time lag between the discovery and the publication time. So that, in other words, it's a little bit like in a for-profit world, that speed to market, time to market, first to release to market. There's millions of tablets, but Apple being the first, obviously a huge advantage being first to market. That still represents a distinct advantage even for the nonprofit sector in their ability to compete. But given that, still an underlying unabiding commitment to actually distribute that information, make that available for the greater community good is an important driver for our maintenance of our 501c3 status. And I think that particular incentive has not necessarily been.
Yeah, let me just quickly comment on that
Curious
before
on
we
that.
go to the next. I know there's someone over here that's been waiting a while. Not just Lou, but I mean the other one. But it's interesting, David, on that one because I'd love to have dialogue and follow up because I know I've talked to AHA and others because we're in the process of looking at some community health work, and I know Illinois just mentioned some of that. And so I took time with my team to look at the 501c3 work with the community health needs assessments, and it runs the gamut. And I was hoping to be able to get it in some type of format. I'm even saying, maybe I can partner with AHA and help to get it to some type of structured format because you have everything from what looks like maybe a administrative intern did that community health needs assessment to some really glossy marketing firm did that community health needs assessments to the real stuff. And so it's not really standardized. It works well enough to check the box from the IRS perspective in terms of your tax exemption. But in terms of what we're talking about here now, at least so far when I've looked at all those community health needs, now it might improve as time goes on or if we highlight the publicity for that to occur. But right now, when I've looked at those, and I've been looking at those across the country, to see if we can use those to be able to align with some of the work that we want to do at the community level. Most of those are really kind of pro forma and not really designed for you to be able to know if you can use those for strategic partnerships.
I'm going to go John and then over here and then come over to Uma.
Yeah, thanks. John Steiner from Kaiser, Colorado. A lot of our discussion about the value proposition to this point has, I think, had an assumption, which is that the value proposition relies on the results of research affecting practice. I just want to extend that a little bit and argue that the process of research is actually a huge part of the value proposition. And in specific, I think one way in which research is helpful is in framing questions, what I think of as well-formed questions. When we work with operational leaders, oftentimes they have a general idea of what they want to learn. Our job is to help them get more precise about what exactly it is they want to learn. And I think the second way then, sort of to follow the whole research process, is in how we collect data, how we measure things. Interactive voice response in our area was developed as a research tool. Now it's largely used as an operational tool for things that have nothing to do with research. So we develop ways of collecting information that actually have substantial operational implications and are part of the value proposition. And the third part is how we analyze data. Our ability to adjust for covariates and to do things that are second nature to researchers oftentimes is something that's much appreciated by operational leaders who understand those problems but don't know how to solve them. So I think my general point is that the value proposition of integrating research with operational and clinical care is actually much broader than just what we learn. It's how we learn it that I think also brings a lot to the table.
Let's go over here. Yeah.
Yeah, Lou Sandy from United Health Group. Thank you for your comments. I wanted to ask about whether you think there's any, this is for Tom and for Rita, whether you think there's any leverage in a network that's focused on evaluating complicated system interventions. And I wanted to use PCMH as an example because you mentioned, Tom, your experience that over time you've gotten better and better results, which is actually consistent with what we found in the 17 states in which we're operating. And yet Group Health reported, I think, David, you worked on this, that your initial foray into PCMH didn't work, and then you retooled and ended up with a much more successful model. And Rita Jama reported, as you know, another trial of PCMH that was a failure, that showed that that approach in that context didn't work. And one of the questions, I think, is whether, does every learning health system have to go and do their own sui generis evaluation of PCMH? And if so, there's not a lot of leverage there, it seems to me, in terms of installing, deploying a better model of care in primary care. And if you could just comment what you think, did you learn anything from Group Health or vice versa? And Rita, any comments on kind of how the authoring, the journal community should better contextualize these kinds of interventions in promoting learning health systems?
Well, it's an interesting question, Lou. I mean, certainly, I think it's you did reinforce the idea that once it was published, everyone could share and learn from it. So, but you're right. I mean, and every intervention is different. Like I would suspect that Susan's reduced MRSA wasn't so complicated, and everyone who did the universal colonization got those same great benefits. Or if not, you would want to identify the factors. But I think even for PCMH, you're right. Certainly, there's a lot more local factors, but still being able to share the article, and in particular, if the researchers or the group has tries to say what predicted their success, what predicted their failure. Even in a failed model, you can say some things were good and were helpful and some things weren't. And then you're right, certainly, healthcare is very local, and so it depends a lot on your patient mix and, lots of other things. The culture at your own institution, the kind of insurance you're carrying. So I think there can still be a learning experience from the sharing, but you do need sort of more granular data because you can't, particularly for complicated interventions like PCMH, just pick it up. But it seemed like there's still a value to sharing that data.
Yeah, Mike, just a comment on that. I think the word on the street, some of you may have heard based on the JAMA article, people have generalized that to say PCMH doesn't work, which is not a correct interpretation given what you said.
And I think part of PCMH means different things to different people too, so it's pretty complicated.
Yeah, if you've seen one PCMH, you've seen one PCMH model, and that's the challenge. To your point, though, if we could take large samples and get to core elements that are critical. I was just reviewing a paper we're actually doing at Geisinger and in Germany and comparing elements. We had different programs. It was around structured care for diabetics, but the details of the programs were different, but there were certain core elements that were the same, and in fact, the results were reproducible across both continents, and so that ability to, with large samples, to drill to core elements and then generalize those, I think is incredibly important. Obviously, United has a tremendous advantage in that space.
Yeah, my only comment on that to add to the panel is that, right after that, then articles came out in managed care, right? So in the same community in Pittsburgh that showed positive results. And so this was where I meant that we often right now have market signals that aren't as clear as those children on the playground, where we know, if you don't have a scar, you don't have a good quality story. In this situation, I think we're still in the early phases of this implementation and getting some coalescing around that. And what I think, to build off of what Rita was, what really is starting to transpire based upon those kind of dual and different reports about that, is that people are trying to get to that granular level of saying, okay, well, what is the difference between the study that didn't show positive results and the study that did show positive results? And now, are we able to build upon those underlying elements? I know that was the conversation with the NCQA and PCPCC, was along those lines of just clarifying what those delineations might actually be.
Make this the last question, and then we'll break for lunch.
I wonder if you'd comment on is, as we're thinking about this integration of research and operations, it seems to me that what ideas do you have for solving the time from new knowledge to application? And let me throw out an idea that should people be funding people not only for generating the new knowledge, but also be accountable for application of that knowledge, and what would that look like? Because the problem we're struggling with is systems that are receptive to able to pick up the new knowledge, I think, Thomas, you talked about, and then the sort of division, and I'm wondering whether you think about whether they should really come together at the front.
I mean, so if you think about some of the things that are happening now, for instance, the CMMI innovation grants, right? They look at generating knowledge, but really around also implementing it. So I think this concept of tying the generation and the dissemination is important. The ability to do that will be the challenge. The ability to do it reliable is a whole separate challenge and probably needs its own body of research, right? But I think that core element, if we're going to maintain enthusiasm, we're going to maintain the clinicians and the patients' interest, and ultimately, some level of funding. Folks want to see the chain all the way completed, so they want to see it from generation to actually changing it. Even understanding that timeline might be many, many years. The ability to chain it, I think, will be important. Yeah, absolutely.
Well, I would just say that by and large, I think a lot of the incentives in academia would have to change for a lot of people, a lot of institutions. I think I've been asking for years, when are the group health faculty going to be, incentivized and given tenure for, getting the knowledge into practice versus getting the journal article published. I think we're a little bit of ways away from that. And I think just knowing that we're close to the top of the hour here, I'll just put a bow around this. And what I heard over the last 45 minutes of discussion, I was taking note of the different incentives that came up just kind of spontaneously, because I think they will all feed into this value proposition ultimately. The social capital, reputation management, ease and speed of information, making it simple and easy. I think synergy actually in and of itself is an incentive. Having that collaborative capability in an organization kind of creates the joy and work phenomenon that I think we would all value. Of course, there's the monetary total cost of care types of incentives, better care. I heard somebody mention that lower anxiety and more peace of mind. If you can go home and sleep at night knowing that you have a strong, vibrant health system that's leveraging the knowledge as best it can, that's going to help. From the patient's vantage, aspects of altruism and knowing that they're getting, that they can either pay it forward and value research as a way to pay it forward to others or benefit from research that's come before them. And then the notion of process as the product, which was John's interesting idea, that the analyses and the tools that we create as part of the research process can benefit operationally across the organization. The one thing I didn't hear come up today, which was interesting, and maybe we'll pick it up this afternoon after lunch, is will the research create better data that can then also support not just the research itself, but the other quality improvement and other aspects of improving care. So I hope we can dig into some more of these a little bit later, and help me thank our panelists, and thank you.
And thank you, Sarah. That was really a great summary, and I really appreciate you doing that. Lunchtime, and we have an hour. This is a good time to both eat, manage your email, and continue to socialize. We'll see you at 1 o'clock.